Good morning, everyone. I'm Dr. Wilfredo Santos, a professor of the Department of Pediatrics of the De La Salle University Medical Health Sciences Institute, and I'm here to discuss about the high-risk infants. The objective of this lecture is to recognize high-risk infants from data gathered from clinical history and from the physical examination of neonates. And these are the following contents of our lecture for today: the high-risk infant factors, the premature infants, the low birth weight babies, the birth weight and age of gestation, how you determine them, and the factors that lead to intrauterine growth retardation. High-risk infants are infants or neonates who should be under the close observation by experienced physicians, namely your pediatricians and or the neonatologists or the pediatricians who have their subspecialty in newborn medicine, and the specialized nurses who are called neonatal nurse care practitioners, who are usually stationed in the neonatal intensive care units. These are the factors that can lead to high-risk infants or being a high-risk babies. And these are the demographic social factors of the mom or the mothers, the past medical history of the mother, the previous pregnancy, the present pregnancy that can have some complications, and the timing of labor and the delivery process. The newborn himself or herself, what are the attributes of this neonate, and multiple gestation, which you all know would be a high risk pregnancy. So for demographic factors, mothers whose age are less than 16 years old or the teenagers and those who are 40 years old are at high risk of delivering high risk babies or high risk infants. And mothers who uses illicit drug, alcohol or cigarette for a long period of time or during pregnancy can also lead to high risk babies. Poverty, since they cannot avail of themselves of prenatal checkup regularly, and those moms who are unmarried because of socioeconomic and emotional factors, and those moms who have emotional or physical stress can also lead to high-risk infants. It is very important that you should take the past medical history of the mother on her present pregnancy or even other pregnancies previous to this present pregnancy. Look at genetic disorders. If there were babies who were delivered with genetic malformation, the presence of diabetes mellitus, or uh, mothers who are diagnosed with gestational diabetes who are uncontrolled during the pregnancy, and this can lead to some congenital malformation. The presence of hypertension, since this can lead to a chronic hypoxemic state in utero and can lead to some uh, complications in the fetus and then eventually in the newborn. Mom who have asymptomatic bacteriuria, especially during the last 2 weeks of pregnancy. Mothers who have systemic lupus erythematosus, since this can lead to fetus and then babies with congenital heart block, and moms who have long-term medication, which can also affect the growing fetus and eventually the baby. High-risk infancy can be diagnosed on previous pregnancy if these following factors were present. So like for example, the presence of intrauterine fetal death on previous pregnancy, or the presence of a neonatal death, the recurring presence of prematurity among the pregnancies of the mom, the presence of intrauterine growth restriction or any congenital malformation that may be present. Also, if there would be incompetent cervix on the mother, which can lead to several abortions or preterm pregnancy delivery. Any blood group sensitization like your ABO or RH incompatibility, which can lead to um, jaundice during the neonatal period or early on the neonatal period. Presence of neonatal thrombocytopenia, which can lead to some bleeding later on. Presence of hydrops, and this may be due to your RH incompatibility or some late onset hydrops secondary to a congenital cardiac problem or an infectious process like your parvovirus B19, and then your inborn errors of metabolism, which can lead also to some complications in the newborn. During the present pregnancy, the following may be identified, like your vaginal bleeding, exemplified by your abruptio placenta or placenta previa, which can lead to asphyxial events in utero and can compromise the oxygenation of the fetus and eventually the baby. The presence of sexually transmitted infection like your TORCH, your Toxoplasma, others like hepatitis, rubella, cytomegalovirus, and herpes. These are congenital infections, no, that can lead to some malformation and also congenital infection in the newborn. Presence of multiple gestation, which can lead usually to prematurity, and also some deformities on the babies because of the uh, mechanical deformation that can lead to some high-risk infants. Presence of preeclampsia and also your premature rupture of membranes. PROM or premature rupture of membranes can be a, a complication or a risk for being high-risk infants if it ruptures more than 18 hours prior to delivery. And then your short interpregnancy time, which can lead to abruptio placenta or some abnormalities in the pregnancy. Your poly and oligohydramnios. Polyhydramnios can lead to some problems in the GI tract of the baby, and your oligohydramnios can lead to some problems in the genitourinary tract of the baby. Acute or medical surgical illnesses of the mom can also lead to some complications to the baby, like for example your hypertension, your diabetes, or a surgical illness like acute appendicitis, no, on the mother can lead to some uh, risk for the infants. If there would be inadequate prenatal care, there should be at least 4 prenatal care prior to delivery, and this can also lead to some complications in the newborn because of the non-identification of the problems during pregnancy. Familial or acquired hypercoagulable states can lead to bleeding during the neonatal period. Any abnormal fetal ultrasonography that can be found, like for example, abnormality in the heart, in the brain, or in any other organs of the fetus, can lead to some complications. And treatment of infertility, which can lead most of the time to multiple pregnancy. And as we have discussed, multiple pregnancy can have its complications during pregnancy and after delivery. During labor and delivery, like for example your vaginal bleeding as in abruptio and placenta previa, and also your TORCH infection and all other factors that we have discussed can also be contributory to the manner of labor and delivery of the baby. It can lead to an emergency cesarean delivery. So labor and delivery can lead to prematurity, okay, or it can lead to a premature baby that may later on present with respiratory distress secondary to your surfactant deficiency. Or if there would be some difficulty in delivery, it can lead to some birth trauma or malformation when the baby is delivered. Or if the baby is post-term, then it can lead usually to some form of meconium staining of the amniotic fluid, and the baby may aspirate the meconium and lead to meconium aspiration syndrome. Or sometimes cord coil or triple cord coil, like you can see in this picture. This can lead to asphyxia and later on the complications of your perinatal asphyxia. Okay. Or if, like for example, there would be forceps delivery, there could be trauma on the head. It can lead also to some complications in the brain, no? Like for example, your intraventricular hemorrhage, especially on premature babies. Upper score, which are less than 4 at 1 minute, may lead to perinatal asphyxia, but your upper score will not be solely an indicator if there would be perinatal asphyxia on the newborn. Sometimes an abnormal or a normal Apgar score may lead to a baby with cerebral palsy. For the newborn, the baby may be small for gestational age, appropriate for gestational age, or large for gestational age. Okay, or the baby may be term or preterm, or the baby may be cyanotic at birth, or with some congenital malformations that you can see in this picture, which is a baby with prune belly syndrome, or a baby with some other abnormalities. So for any given gestational age, the lower the birth weight, the higher the neonatal mortality. So if the baby is intrauterine growth restricted, then there would be more complications on the newborn. And for any given weight, the shorter the gestational gestation or the more preterm the baby, the higher the neonatal mortality. So less than 1,000 grams at birth and less than 28 weeks gestation, and those who are more than 4,000 grams at birth and more than 42 weeks of gestation are usually at highest risk of mortality. The less than 1,000 grams at birth babies are called the extremely low birth weight babies, and the less than 28 weeks are the extremely preterm babies. The more than 4,000 gram babies are called large for gestational age babies, and the more than 42 weeks age of gestation babies are called post-term newborns. So babies who are preterm are most prone to develop your RDS or your respiratory distress syndrome and other complications of prematurity. Like for example, the presence of intraventricular hemorrhage, the presence of necrotizing enterocolitis, and other forms of your complications in the premature babies. For babies who are large for gestational age, usually they are babies from moms who have diabetes, so they may be macrosomic, meaning they are large, so usually the problem here would be the difficult delivery, and they may sustain some birth trauma, and usually the trauma here is your clavicular fracture, and because of the difficult delivery of these babies from the introitus. The lowest risk of mortality will be babies having a birth weight of 3,000 to 4,000 grams or 3 to 4 kilograms, and the age of gestation, the term babies who are 38 to 42 weeks age of gestation. Multiple gestation pregnancies, the incidence is highest among blacks and East Indians, but the lowest among Asians. And usually there's a family history of twin pregnancy, or usually a result from simultaneous maturation of multiple ovarian follicles. That's why there are two or more fetus which were simultaneously fertilized. Usually also this would be the cause of treatment for infertility, so when several embryos will be fertilizated because of the process of in vitro fertilization. The problems of twin gestation are the following, the polyhydramnios that we have mentioned, the preeclampsia, the PROM, prematurity because there are two or more babies in utero, and this can lead to a premature delivery. Sometimes abnormal presentation, the first baby may be delivered normally, but the next baby can rotate, and becomes breech, or place himself or herself in a transverse lie. That's why the second baby can be delivered by a cesarean section. If they are preterm, they are more prone to develop respiratory distress syndrome and perinatal asphyxia, and some would have congenital anomalies, and this is what we are afraid of, twin babies having twin transfusion. No, the one baby would be smaller, and the other baby would be bigger. One baby would be pale, and then the other baby would be plethoric or with increased hematocrit levels. No, because of the abnormalities in the vessels that may connect the baby's placenta. So live-born babies who are delivered before 37 weeks age of gestation after the first day of the last menstrual period are considered premature infants or babies. And these are the pictures of a preterm baby, as young as 28, 26 weeks. In our country, usually the viable age, or the age that they can live is about 25, 26 weeks. But in developed countries, they can live as young as 22 to 23 weeks age of gestation. So these are the identifiable causes of preterm birth. No? For the fetus, there could be fetal distress in utero that can lead to eventual delivery. Again, if there would be multiple gestation, if there would be erythroblastosis, like for example, uh, hydrops that can be immune secondary to the Rh incompatibility, or the non-immune hydrops that may be secondary to a late onset cardiac problem in the fetus, or an infection, like in parvovirus. And then your placental causes would be like placental dysfunction or placenta previa or abruptio of placenta that can lead to preterm delivery, and also a uterine abnormality in the mother who has bicornuate uterus, or an incompetent cervix that can lead to prematurity. So these are also the identifiable causes of preterm birth, like preeclampsia in the mother, or chronic medical illnesses like cyanotic heart disease and renal disease, or any infection like Listeria, group B strep, a UTI usually upon delivery, vaginosis caused by some fungal infection, or your chorioamnionitis, which is consisting of the triad of maternal fever, tachycardia, and abdominal pain, and a foul-smelling amniotic fluid, or a history of drug abuse. Others would be your PROM, as we have mentioned, your polyhydramnios, and sometimes trauma. Iatrogenic sometimes may be a wrong computation of the last menstrual period, and then the mother was subjected to an elective surgery or cesarean section, and it turned out that the baby was premature. Okay? So these are the classification of infants according to birth weight. You have your low birth weight babies who weighs less than 2,500 grams, your very low birth weight babies or who weighs less than 1,500 grams, and your extremely low birth weight babies who weighs about less than 1,000 grams. For the classification according to birth weight and age of gestation, you have your large progestational age babies who belong to the 95th percentile for weight, and then your SGA, or small progestational age babies who are less than the 10th percentile for age, for weight, and your IUGR, or intrauterine growth restricted babies, who are the same as your SGA, but the cause is always pathologic. So for large progestational age babies, usually, as I've mentioned, they are caused by the uncontrolled diabetes of the mom, but sometimes may be normal because of constitutionality, meaning the mother and the father are also big in terms of weight, and height. And usually the complications here, as I mentioned, would be birth trauma, and then your hypoglycemia if they are babies from mom with uncontrolled diabetes, or some congenital malformation. And then your small progestational age babies, since they also don't have reserve more for their sugar, would also be exposed to your hypoglycemia, hypocalcemia, hypothermia, since they are small. Differentiate SGA from IUGR. IUGR would always be pathologic in cause, while SGA may also be constitutional if the mom and dad are also small. And these are the factors often associated with intrauterine growth restriction. No? For fetal, the chromosomal disorders, the congenital infection or congenital anomalies, the exposure to radiation, multiple gestation, and insulin deficiency in the mom. No? For the maternal factors associated with IUGR, it could be decreased placental weight, decrease in surface area, a villus placentitis, like for example, there's an infection, no, a tumor, a placental separation, or a twin-twin transfusion syndrome. For the placental factors, it could be toxemia or hypertension, and then your hypoxemia, like for example, the mom is living in a high altitude place, or the mom is having cyanotic cardiac or pulmonary disease that can lead to a decrease in the oxygen delivery through the placenta to the fetus. Presence of chronic illness, again, your sickle cell anemia may affect your delivery of oxygen, and the use of drugs, like your narcotics, alcohol, the cigarettes, due to the nicotine, that can cause uh, constriction, of the blood vessels that can lead to decreased oxygenation in the placenta, cocaine, and some anti-metabolite. Your IUGR or intrauterine growth restricted babies may either be symmetric or asymmetric. Symmetric, the weight, length, and head belongs all to the less than the 10th percentile. So lahat, the weight, the length, and the head are small. Usually, the insult here happens at the early onset of pregnancy. Like for example, there was an infection or a chronic maternal illness or a congenital anomaly that can lead to these small babies. And then your asymmetric IUGR can lead to your length and head circumference, which are normal, but the weight is below the 10th percentile. The insult here happened usually at the late onset or late in pregnancy, and there could also be an effect of acute maternal malnutrition. But a chronic maternal malnutrition can lead to asymmetric IUGR, okay? Or a cardiac abnormalities of the mother that can lead also to the poor oxygenation being distributed to the placenta to the fetus. So in summary, your high-risk infants have several factors that we have discussed, and the different factors may be maternal, maybe placental, or maybe neonatal. And then you have your prematurity as one of the leading causes that may lead to a high-risk infants, because you all know that your prematurity may bring about a lot of complications, starting from your development of your respiratory distress syndrome to hypoglycemia, hypocalcemia, necrotizing enterocolitis, and other complications of prematurity. The low birth weight also would have those complications, as well as babies with intrauterine growth restriction. And your birth weight and age of gestation may have some effect on these babies who are considered high-risk infants. So for your reference, you can use your Nelson Textbook of Pediatrics, the 21st edition, and all of this can be found in this textbook for your easy reading. Thank you very much for all your attention.